Hi, everybody. I want to welcome you to E in the Loop, and I want to welcome a very special guest today, Dr. Ben Youdelman. We have a history way back. We were just talking about that our dads knew each other uh, during the war. That's how they met.
Yeah, we're not really sure, but we know that they certainly were friends
For a long
back about
time.
60 years ago, 70 years ago.
Yeah. Dr. Ben Youdelman wasn't a doctor when I first met him. Actually, he was, his mom was pregnant with him. So I've known him a very long time. I would say that my dad truly considers Dr. Youdelman probably his third child. I would comfortably say my dad's 92 and Dr. Youdelman has been an incredible part of our family. Ben, would you like to introduce yourself?
I would love to, Erika. So my name is Ben Youdelman, and I am a cardiac surgeon who specializes in aortic surgery and endovascular aortic surgery as well. I work at Maimonides Medical Center, and we have a Maimonides Aortic Center in Brooklyn, New York, and it is the only aortic center serving the 3 million people here in Brooklyn, and one of 5 aortic centers serving the 12 million people in the New York area. So it's a very special job and specialized subspecialty of heart surgery.
How long have you been there?
So I've been here going into my 10th year, starting May 1st, and I am 26 years since medical school, and I know it's crazy, right?
It is crazy. How did your journey begin?
So, I was very interested in the sciences, not so interested in the softer sciences. As I tell my kids now that I've got kids who are explaining to me why I got to this location, they take these exams and they say, well, science is great because there's an answer, as opposed to, trying to have a conversation about what the story or poem means to me or what's going on in the politics of the 14th century. I said, well, yes, that's why I like science, because there's an answer, and it's easy. If there's an answer, then you could just study the answers. It made it a lot simpler. But I think fundamentally, and now that I see my kids as they're germinating, I think, I always really enjoyed the social aspects of being involved with people. And when you start to look at careers and you figure out all the things that you like to do, and then you isolate the sciences, there's very few areas where you can be very deep in the sciences and be also very social. And the combination of those two things made it very obvious to me after I was accepted to a PhD program in physiology, where I was asked to adopt some stranded seals and test them and do all kinds of stuff. I told the PhD that I actually had changed my mind. I wanted to go to medical school, and he thought I was completely out of my mind, as did all my friends. But it became clear to me that if you really want to help people and apply science, it's probably the best area.
What made you want to be a cardiac surgeon?
Well, see, now it's you start going down the slippery slope. You like the sciences, you go to medical school, you like to work with your hands, then you like instant gratification, and you walk through surgery, because I had to become a general surgeon first. And in general surgery, there's a number of subspecialties where the gratification is not instantaneous, but in the vascular surgery world, it literally is instantaneous. If you're sewing two ends of something together, and then you restore the blood flow, it either bleeds or it doesn't bleed, or it bleeds a little bit and then it stops bleeding. And once you get into those areas, it's quite clear that there's only so many pathways that you can go down. And I really have always liked being sort of the person that sort of does something and then it's done and then I can move on to something else. It's not exactly that way, as I've
No.
learned, but in terms of the instant gratification jobs, this is the best subspecialty, because honestly, all the problems that you run into in heart and aortic surgery, probably 90% of them get solved in the operating room at the time of surgery. And then the other problems that occur, you usually know about them start going into the operating room and that those are going to be issues that you're going to have to contend with afterwards. So it's sort of like fewer hidden secrets, fewer surprises. There are always some, but not quite as many as some of the other subspecialties.
Was there something in your training that made you want to focus on the aorta?
There's a lot of information in the weeds, and I'll try to simplify it for you. Basically, when you go into cardiothoracic surgery, which is hearts, lungs, and everything sort of inside the chest, and a couple of things outside the chest, you basically have to decide which thing do you like or hate the least. And if you like heart surgery and the associated operations that you do, you have to do aortic surgery because it's part of the job. And if you go into some of the other subspecialties, you have to do something else. And once I started to do aortic surgery as a resident in training, I realized just how phenomenally interesting it was. And it became something that I was attracted to. And then the last piece of information, which is kind of unexpected, was that I went to medical school to become a pediatrician, decided that I really loved kids when they were well and really did not like kids when they were sick. Like I don't like even like my own kids when they're sick, but I'll deal with them. And then you realize you want to follow patients for life, because that was why I thought it would be really interesting to be a physician. And in heart surgery, there's only a couple subspecialties where you get to follow patients for life. And for me, aortic surgery was the most interesting operation, was places where I could follow patients for life, which obviously we're going to get into. And the combination of the two made it really perfect for me, my personality, my desire to have instant gratification and things like that.
For our listeners, can you explain what the aorta is and how it's important to our health?
The aorta is the largest blood vessel in the body.
Okay.
It looks a little bit like this. It is not red, but there's blood that goes through it. So anytime there's blood going through it, we say that it's red. And these are the blood vessels that go to the brain. Pictured right here is the area where the heart would be. And it goes up and over. It gives off the blood vessels to your arms and your brain. And then it goes down the back. And then when it goes down the back, you can encounter something called an aneurysm, which is what this is, an enlargement. And it goes down and then it goes into the belly, and it gives rise to all of the blood vessels of the body, all of the arterial blood vessels. And that's the aorta as in a sort of in a nutshell. That's an abnormal one with an aneurysm. And so in order to operate on it, you can't have the heart beating, you can't have blood running through it. You have to isolate the areas where you're going to work and keep the blood going to the heart, or protecting the heart from problems, keep blood going to the brain, and or keeping the brain protected in some other way, or keeping the blood going to the body, or keeping the body protected in some way. And so it's a combination of very complicated circulatory management, where if I want to operate on something in this area going to the brain, I have to stop the blood flow to the heart, I have to stop the blood flow to the brain, and I have to stop the blood flow to the body for a short period of time, get the body cold enough that it doesn't use a lot of energy, and intermittently run blood flow to various organs while I'm doing the operation at the same time. So it makes it a little complex, and it's perfect if you like to do multiple things all at the same time, because
Multitasking.
yeah, I mean, you could call it multitasking. It's now called attention deficit disorder, which we all know is basically a superpower for people who have to do multiple things at the same time.
They call it a silent condition of, they don't know disease, the aorta disease. Why is it so dangerous and difficult to detect?
So the interesting thing about aortic disease, and I'll use this as an example, is that you could have this condition in your body, which is clearly abnormal, and you wouldn't know about it at all unless one of two things happen. One would be it ruptures. We all know what rupture means. And then the other thing that can happen is that it can tear on the inside and travel in the wall, not rupturing out into the body, but actually rupturing back in. And the tear in the wall is where blood is dissecting through the wall, and that's called an aortic dissection. But the dissection is, in fact, the blood dissecting through the wall. And those two conditions will bring it to your attention if you have symptoms. But the overwhelming majority of patients will come to me in my office having had a CAT scan or having had an echocardiogram of their heart or an MRI or something for a totally unrelated condition. So I would say 3/4 of the patients that come to see me are really, really disappointed. They really don't want to see me. They have absolutely no symptoms related to it. And then a subset of them, I tell them they need a big, huge operation. So let me walk you through this. You're a person walking along, you get into a car accident, you have a little bit of a cough, your back hurts, you get a CAT scan, MRI, echo, and somebody says, oh, you have an aneurysm, you have to go see Ben Youdelman. So they walk into my office, totally asymptomatic, and I say, well, you have a condition. Anybody in the family have a problem? Classically, they'll say, no, no one has any problem like this at all. Well, what happened to your parents? And they'll be like, maybe the patient will be maybe 40, 50 years old. And they'll say, oh, my parents lived a long life. My dad died at 65 and my mother died at 70. And I say, really, what did they die from? And then they'll say, well, my mother, she was just, walking around the house and she just dropped dead. She didn't suffer at all. I said, okay, what happened to your dad? Oh, my dad was driving a car. He got into a car accident. They brought him to the hospital. They said he needed emergent heart surgery, and he had some sort of emergency heart surgery. He was okay for a number of years, and then he died after that. And then I have to tell them the sad news that what they were told and what they have may be related, but not necessarily the information that they had gotten. Doesn't mean that it was definitely what I'm saying, but that my job is to protect and save the life of the person sitting in front of me. And when somebody sitting in front of me at the age of, let's say, 50 has an aneurysm that's large, and then they tell me of events in their family where somebody died and they were said they had a massive heart attack, something like that, I have to make an assumption, which is that in order to protect this patient, I have to assume that that person could have had an aortic problem that was a dissection or a rupture. And now an asymptomatic person sitting in front of me, not only did they have an unrelated problem, are they seeing somebody they don't want to see? I'm now giving them terrible news. And sometimes I then tell them that they're going to need an operation that carries a risk of death of maybe 2% and a risk of stroke of 1 to 2%. So I'm universally hated, which is okay at first. And then after that, I'm universally appreciated because
Sure, because you saved lives.
I'm pointing out something that no one has ever pointed out to some of these patients. Now, I don't want anybody to think that this is all my patients, because there's certainly a number of patients who come in very much more informed. But one of my huge vocational hobbies is to just educate people about aortic disease and put them in a situation where they're not walking into my office, because let me tell you, it helps me. I would rather somebody walk into my office not having done some sort of internet search, but with true knowledge and understanding the generational and genetic impact of aortic disease and all these diseases, heart disease, stroke, diabetes, cancer, and aortic disease, all run in families. And most people, despite the fact that they have, families who have medical problems, they are like, no, not me. I'm just going to have chia seeds and flax seeds, and I'm going to have oatmeal 15 times a day, and I'm going to exercise all the time, and I'll be just fine. I wish that was the case, but unfortunately, my job security depends on the fact that this is not the case.
No, and it can be genetic.
It is genetic.
Yeah, it is genetic. You're part of the Think Aorta campaign, which, if you could explain what that is and how important is it to raise awareness?
So it goes back to when I came to Brooklyn in 2017, and I started a small support group that was associated with all of the patients who'd had aortic surgery at Maimonides and all the patients in the greater Brooklyn and New York area who wanted to join us. And it was called Aortic Bridge. And it was basically a concept of bridging the communication between patients, between practitioners and patients, between patients and families, families and other patients, and things like that. So it kind of had a nice connotation. And we did a number of events at the hospital up until 2020 when things got a little interesting for all of us. But I was very, very aggressive about promoting this idea in an area of New York where no one's actually ever even thought about having support groups for aortic disease. There's a wonderful series of groups of support for cancer, for heart disease, where people have bypass surgery, and a number of other medical conditions, but not for aortic disease. And once I established that and became a little bit of a social media source for my patients, I was actually recognized by a gentleman from the United Kingdom who had started this Think Aorta campaign around the same time, maybe a year before. So his story was very interesting. He had an aortic dissection, which was an emergency, while he was on business in London. But his home is about 6 hours away, very, very far away from any aortic center. And it became obvious to him in the stress of his recovery and his understanding that not only did he have this problem, but he had it in his family, that the number of people in the UK that knew about aortic disease and understood the importance of this was very, very, very few. So he started the Think Aorta campaign to raise awareness, to have a support group in London and in the UK as a whole. And once they got it rolling, he realized that it was really important for him to engage some people in the United States, because if we can join them, then we can really, turn it into a global movement. So he reached out to me and a number of other people and ultimately settled with myself and a woman named Karen Anderson, who had started what became a national support network called Aortic Hope. And she and I started working together and brought the campaign to the United States. And it had a number of parts to it. But first, what we did was we mailed 10,000 posters, so 2 posters each, to every emergency department all over the country. And we did that twice. And then, working with the mothership, as we call Gareth and his team in the UK, we launched Think Aorta, Think Family, which was the larger consideration, which I was far more interested in, which was explaining to people that if there's an emergency and you have an aortic dissection, well, that's one problem. But isn't it much better to know that this runs in families, get checked out? Because if you think about it, Erika, in terms of emergency surgery and elective surgery, and I take one patient and I split them into 2, and one of them comes to my office, incredibly disappointed to meet me, and I tell them they need an operation. They go to surgery with a risk of death of 2%, maybe 3% if they have medical problems, and a risk of stroke of maybe 1% to 2%. If they don't go see a physician and go on to have an aortic dissection, and if that dissection is complex, which many of them are, they could need an emergency surgery that carries a risk of death of 30%.
Wow.
Risk of stroke that may be as high as 15%. Now, that's not all the cases, but remember, there are plenty of patients who have a dissection and do not make it to the hospital. So the ones that make it to the hospital, many of them, if they're very simple, they carry a risk of death of only 10%. If they're complicated, they can carry a risk of death of 30%. So what I'm pointing out to you is the thing that I don't think it was as appreciated by the group of patients. And to some degree, I understand there's a bit of a, stress response and a lack of desire to go backwards and say, what could I have done to avoid this and this and that? People don't like to do those things because it's very, very upsetting in every possible way.
Mm-hmm.
But when I came in and said, here, this is not about you, this is about your family and your generations to come, and that the information about your healthcare is critically important, and we should start with the aorta because it's so dramatic. And we launched the Think Aorta, Think Family campaign. And it has been universally sort of adopted by all the support groups. And it has percolated very slowly into a lot of the medical centers and a lot of the aortic centers with regards to family screening and things like that.
What should families know about screening and their inherent risks?
I don't like to just focus on the aorta. So, I mean, basically, whatever your parents had, whatever your grandparents had, whatever your siblings had, that's what you're going to get. I mean, it's a very simple thing. You can have other things if you're, choose to, if you want to smoke a lot and do lots of drugs that damage your system and, get involved and not eat well. Yeah, you can make things worse, but it's hard to make things better than your genetics. And that's where the
Yeah.
surveillance comes in. So the critical thing that you need to do is realize whatever your parents had, whatever your grandparents had, are your risk factors. Once you establish your risk factors, you just have to be honest with yourself and your siblings and then your children and your nieces and nephews and explain to people what you have and what you had and move forward. There are very clear guidelines for this with regards to the genetics of cancer. We've all heard of the BRCA genes. We've all heard of a lot of people saying, oh, if you have heart disease, that you have to be careful. You may get heart disease if your parents have it, and all of these risk factors, which we classically know. But the problem is that people don't face it forward and say, well, when you turn 40 or 50, if your parents had bypass surgery or heart attacks when they turn 40 or 50, you need to get checked out. You need to do all of those things. And it's true for all of them. So, heart disease, stroke, diabetes, cancer, aortic disease. So, what do? Get a doctor. So, what do women
Yeah.
do? Women are smart. Women have doctors. They go see doctors almost every year at a minimum, and they get blood tests and they, do all the things, whether they have children or not, and they take care of themselves. Boys, on the other hand, boys don't even know what a doctor is unless they've run into one of two problems. And we all know what those two problems are. One of them is that they can't poop. The other problem is everything in the front. So the problem is that erectile dysfunction and difficulty with constipation, they tend to occur, around age 50 or 60 for most men. And that's the time that they go see a doctor. It's pretty rare that I meet men under the age of 50 who've even seen a doctor unless they are in a job where they are forced to do it, right? Firefighters always have to go see the doctors. Policemen have to go see doctors. A lot of people in healthcare have to go see doctors because we get yelled at all the time.
So do most men have this disease versus women?
All comers, so from age 18 to age 80, it is 2/3 men and 1/3 women. But like most heart and cardiovascular related diseases, it's probably 4-1 in the 20s and 30s. And then in the 70s and 80s, it's probably equal. So it's over the course of life. And we do know that women are protected from cardiovascular risk factors because of female hormones early on in life. But then as those hormones trail off into menopause, then they're less protected and then they have to really be much more careful.
Very interesting. You founded the Aortic Bridge to support families. What inspired you to do that?
One of the things that I mentioned was that I really wanted to follow patients for life. So how do you follow patients for life? Well, you have to have a relationship with them, and then they have to like you enough to want to hang out with you when it's not necessarily, their office visit or they're scared because of the results of a blood test or a study. And so we started just having the patients come to the hospital. We had lunches for them and have them meet each other. They meet each other, they meet our team, the preoperative patients, the postoperative patients, the families. They come in the door and they meet us. It becomes a completely different dynamic when eventually they come to surgery. They're not less scared, but they're more comfortable with the people who are going to take care of them.
That's
And
nice.
as time went on, the best thing that's happened and in the process of the aortic bridge is we have this annual walk, um, And this is going to be in 2026 is our ninth year or ninth anniversary.
Yeah, tell us about that event. I would like to participate.
You absolutely can. So all we do is we meet just at the base of the bridge near Cadman Plaza Park, where the promenade takes off, and we all gather there. We provide T-shirts, and we all wear T-shirts, and we carry these signs that you see behind me on a big stick.
Yes, and they say think family,
Think
aorta.
aorta, think
Yeah.
family, and they have the think aorta and all of the concerns about aortic disease. And people ask us questions like just strangers, but we've built it up over the years. And this year we had about 220 people, and we met there, and we sort of dribbled and drabbed across the Brooklyn Bridge to the Manhattan side, walked back to Brooklyn. Then we all met at a really nice pizza place down in by the water, and had a great time. And the best part for me is that I get to introduce these patients who've maybe just had surgery in the last 6 months to patients who are out 10 years. And I introduce them. I say, you talk to you right now.
So inspiring.
I can't tell them what it's like to have the surgery. I've never had it, but I can definitely tell them the people that they should talk to help them through it. And even people who've had some of the problems associated with surgery. There's no surgery that's perfect. People have pain, discomfort, they have trouble with breathing and coughing and getting home, and their family's understanding and stress. And I don't know if you want to talk about it now, but one of the big problems that occurs is the mental health aspect of it.
With that, I know that PTSD is quite common. How is the emotional part of this recovery?
Yeah, so working with the patients like Karen, who's my co-manager of the Think Aorta United States team with a number of other patients, and the gentleman from the UK who is a patient, sitting and talking with them, the emotional aspects for them is enormous, let alone the emotional aspects for their family, who are walking along with them one day or hanging out and having dinner, and in an instant find out that they are going through a life-threatening emergency. They have a lifelong threatening problem that probably will shorten their life. And they have to contend with this every day, all the time, all year long, complicated, difficult feelings, every ache and pain. You think you're going to drop dead, things like that. It's really unbelievably difficult. So one of the huge aspects of the Aortic Bridge group was to have a full-time psychiatrist work with our patients. So we initially started by engaging the psychiatrist who has been very involved with the cardiac surgery program, including the ventricular assist device and transplant patients and things like that, who require a psychiatric evaluation. But no one's ever specifically asked the aortic patients to have this problem, to be evaluated, but we know that they need some assistance. So I asked that the psychiatry team see every patient every time somebody gets admitted to the hospital. And what we found was that the degree of stress that they were under was significant. Patients who have aortic disease, whether they're 1 month out, 6 months out, or 10 years out, complained of anxiety and stress related to every possible aspect of their life. And we used the various tools that have been out there for a long time to look at evaluation for a preliminary diagnosis of post-traumatic stress, evaluation for quality of life, and one of our students who went on to become a cardiac surgery nurse, she introduced a evaluation of patients' engagement in exercise and physical activity. She herself was a Division I swimmer, and it was very important to her in her life. So there were these 3 different evaluations mixed up and jumbled up in a questionnaire. And all we did was we mailed these out to patients across the country. And as of today, we are sitting on about 1,500 responses over the past 5 years and have evaluated these responses in every possible way. And what we saw was that the incidence of a preliminary diagnosis of post-traumatic stress disorder in some of these diagnoses can be as high as 50%. And
Wow.
that doesn't mean that it maintains that level over the course of time, but what it means is that people's difficulty with going to doctor's office, taking their medications, discussing this, um, being engaged with their families, participating in physical activity, engaged in their sexual activity, engaged in their quality of life, has this diagnosis negatively affected them. And what we found is that it's quite dramatic, that they go from being functional people with a background post-traumatic stress level of about 5% up towards 30, 40, 50% in many of these patients. And it's not just that, it's a very specific diagnosis. But if you just go down to like the basics, like, have you enjoyed, going out with your friends? Have you enjoyed, playing sports? Have you enjoyed taking trips? Have you enjoyed flying in a plane, traveling, things like that? Many people talk about not wanting to be away from their physicians because they're nervous that something could happen. And there's a whole host of things.
Are there any advancements in cardiac and aortic surgery that you're extremely excited about right now?
I am. Would you want you want some visual stuff? I got
Yeah.
some cool pictures. So we can start with my initial picture. So here's the aorta, and there's the aneurysm I talked about.
Right.
If you turn it around, this is actually an endovascular stent graft. So unlike going into the chest, making a big incision, we make a puncture in the groin into the artery, which we close in advance, and we can advance this up into the chest. We can deliver this device, redirect blood flow away from this weakened aortic wall. We pull all the delivery system out, close up the hole, and the patients go home the next day with basically no incisions.
Wow.
Now,
Wow.
these operations like that I described have been going on for quite some time, but there are lots of advancements in aortic surgery, and these advancements were designed to decrease the chances that the patients would need repeat operations and decrease the chances that the patients would um, have a problem with the complications of the operative procedure itself. So just to give you an example, this device, which I would normally have to put in with an open operation and then attach each one of these directly to the head, okay? We can now put in these devices that I just described, and some of them, like this, they look like those little finger games, right, when we were kids.
Yeah.
They have little portals on the side. So if you can imagine, this goes up and this goes forward. And instead of putting in the device where I have to cut here and make connections with, let's say, this device, I can actually go through the groin in some cases, not all cases, and put a branch up into the vessel that goes to the brain. And then this can go towards the heart. And ultimately, we can reconstruct a lot of these aortas with endovascular procedures with less pain, smaller incisions, or sometimes no incision, or incisions maybe in the neck where we redirect the blood flow and allow us to place the grafts through the groin in addition to do them through the neck, which is sort of a hybrid approach. The operations close to the heart have to be done with open procedures with incisions in the chest, but even that is not necessarily as much as it used to be. most of my operations now that I make incisions, instead of cutting down through the whole bone, which is about the distance of 7 ribs, I will actually only cut down 4 ribs and leave the bottom portion of the sternum intact, which actually hurts less, gets people back to work a little faster, makes people a little bit more comfortable post-operatively and quicker. So all in all, it's just a better approach if you can do it less painfully. And these advancements have allowed us not just to do this better, but it's allowed us to operate on patients who maybe historically we avoided operating on them because the risks were too high. They would wind up very physically debilitated. The risk of stroke was very high. And that still is actually the Achilles heel of a lot of these procedures, because while we have great ways of protecting the heart, the issues of protecting the brain are really, really challenging. So we're working on advancing the field, which has slowly but surely gotten to the point where we can do a lot of these big operations much more safely. The part about extending the patient's lives beyond what has been historically about a 50 to 60% mortality after these big aortic tears or ruptures that we can save, that we're not sure about, because a lot of the technology in the last 5 to 10 years has not allowed us to have a 10-year analysis of patients. But hopefully that's what is happening, as we're moving this forward.
If there was one message you want listeners to remember about aortic health, what would it be?
The most important message is that things are not as they seem. If you have family members who have unexplained sudden death, any sort of aortic disease, any sort of massive heart attacks, any sort of situations that were unexpected, they had bleeds in their brain, if they had ruptures that you hear a story that had to be dealt with emergently and they didn't survive, but no one got an autopsy. It's important that you take the information that was given to you with just a little bit of a grain of salt, because unless an autopsy was performed and someone came back to you and handed you a piece of paper and said, this is what we found, if you present yourself with an aortic aneurysm yourself, or even if you don't, if somebody in the family has one of these events, go to it, get a doctor, first of all. If you're a boy, get a doctor. And then go to the doctor and explain to them your family's medical history, your siblings, your parents, even your grandparents. That's only, that could be 8 people or 9 people. You should know about their health care. And the other side is also true. Talk to your siblings, talk to your children about your healthcare and your issues, because the information that you give them and that you put on their medical record and that you hand them, these are really gifts to help them to live as long as possible.
That was great. Yeah, great insight, great advice. Thank you so much. Been an incredible guest and an incredible person. Thank you
Thank you, old
so
friend.
much.
It's a pleasure. It's a pleasure. And hopefully we'll be able to spend some time together. I'll come see your daddy soon.
Oh, I hope so. I hope so. He asks about you.
He should. I'm great.
He does. I know. He calls me Ben all the time.
I love you. I love you, Dad.
Yeah, I loves you too. We all love you. Thank you for everything.
You're welcome.
We were amazing. This was so insightful. I mean, for me in general, and I know for the listeners, but I learned a lot. Thank you.
You're welcome.